want to give a warm welcome to Dr. Joshua Rosenthal from the Fogarty International Center at the U.S. National Institutes of Health. Dr. Rosenthal and I began working together about 5 years ago in a really integral way as part of the household air pollution research, the HAPPEN trial. And this is one of my main research interests, and also something that Dr. Rosenthal has a lot of expertise in, as a strong interest in. And I also think that it's interesting to point out that the career path that he followed through ecology, I think, is a great example of how people who contribute to public health do it in a very interdisciplinary way. And he has interests more broadly beyond air pollution and clean cooking, but broadly in public health, the environment, and international development. Other interesting, important projects that he's a part of at NIH include founding and co-leading the NIH Climate and Health Working Group, as well as the GeoHealth program, and which is an interesting training of program and research that goes on related to global environmental health in many countries around the world. So I think I will now turn it over to Dr. Rosenthal to present some work that he's done and some of his ideas related to environmental health and implementation science. Thank you.
Thank you, John, for that introduction. When John and I first talked about this talk, well, first let me say thank you for inviting me, and thank you all for coming to listen. And I hope it's useful and provocative for you. When John and I first talked about this, we talked about the idea of implementing science in clean cooking and environmental health more broadly, because I have been doing some work in that area in the last 5 years or so. And it's a little different than the basic health effects research that we have been mostly focused on in the HAPPEN trial that John referred to. But with apologies to John and begging your patience, the rest of you, I want to admit that when I sat down to write this talk, it's not really where my head is at right now. And so what I put together is a big picture talk that I hope will be provocative to think about not only household air pollution, but environmental health broadly in today's context. And so it's a little more philosophical and a little less detail-oriented of a talk. I hope it's useful, and I would be happy to talk with people later if they're interested in knowing more about implementation science in particular, and point you to some resources. I'll touch on it briefly, and I will also touch on household air pollution, but I'm also going to bring in the context of climate change, which has been a substantial area of focus for my time in the last year in particular. So with that, let me share my screen and put the talk up. Okay, so you can see, I think, the cover slide. John, you may recognize that image.
Oh, yeah, the hike, the hill in Antigua.
Yeah, it's a photo I took when we were down there last, a couple of years ago now. So I'd like to step back from the details of research methods and very specific outcomes to ask some big questions about how public health research, including but not exclusively epidemiology, can and should be approaching science. And so I'm titling this, Can Public Health Be Both Consequentialist and Reductionist? So I started thinking about this term consequentialism after reading, or more accurately listening to, Ibram Kendi's book on how to be anti-racist, where he challenges a lot of our assumptions about the relationship of our intentions to the outcomes and focuses on the outcomes as what really matters more than why something works. Does it work the way we want it to? So I'm calling that consequentialism. And to try to apply that to the public health context, let me point to a couple of big areas in public health, both in global health, where I spend most of my time, but also in the US and in the developed world. And that is the large number of often very well-funded investments in research and interventions have frequently, if not generally, failed to achieve the outcomes that we're looking for, including diarrheal diseases, household air pollution, pandemic and infectious diseases, tobacco use and all associated morbidity, obesity, just as a couple of examples. And if you look at it that way, you will say, well, maybe public health hasn't had such a great track record. I don't think that's really true. I think what it says is that when we start programs, we need to think a little bit more carefully about the outcomes and how we're getting there. And I'll spend a little bit more time talking about that. The flip side of consequentialism is sometimes we start things that we know are well-intended, seem like they're exactly the right thing to do in the name of public health, and create other problems we were not anticipating. And the classic example in the public health space here is the arsenic poisoning that has occurred on a massive scale in Bangladesh and northern India. Beginning in the 60s, development agencies around the world saw diarrhea as, and still see diarrhea as, one of the foremost health challenges in many low and middle income countries. So access to clean water was the raison d'etre, and the tool that seemed most sensible at the time was because people were accessing surface water that contained a lot of runoff from improperly disposed of fecal material and other waste. They built deep tube wells well down into the ground to pull up clean water. Well intended, except what they didn't realize was that there were high concentrations of naturally occurring arsenic at those levels in the groundwater, and it created epidemic cases of arsenic poisoning with significant consequences in a wide range of associated physical and nervous system outcomes. So the point here being is, well-intended programs may also have unintended consequences. Another way to look at consequentialism is to think about how interventions that have made major impacts, we believe, on public health were not necessarily intended as public health programs when they started. So a lot of us in the household air pollution community look to this massive investment and major progress that has occurred in India over the last 5 years under a network of programs, the sort of principal program called the PMUY program, Pradhan Mantri Ujjwala Yojana. Apologies to Ajay and others who can pronounce that properly. These are programs, while public health was part of the thinking in the policy community, that's not how they were pitched to the general public and how they brought people on. These were poverty alleviation tools. This was about making cooking faster and cleaner and saving time for people and making it easier, reducing the burden of drudgery. We believe that this intervention has had a significant reduction, created a significant reduction in daily emissions of fine particulate and other toxins from combustion of solid fuels. Still measuring that. There are lots of problems with the program, but it was a massive effort with a probable public health major benefit. But it wasn't about public health to start with. So when we think about these interventions today, we often, I think I got this slide out of order, but all the dApps, we often think about how are we going to design interventions for public health that will make a difference in the outcomes we want. So we don't have unintended consequences, that we understand what they'll do as well as possible before we scale them up. And in the last couple of decades, randomized controlled trials have been held up as one of the best methods. Now, I came from the world of ecology where this design is decades older than perhaps they are in the public health space, where people were doing this because it was easy to do on plants and wildlife, and looking at complex experimental designs. It's a bigger, more expensive, riskier operation when you're dealing with real people with lots of ethical complications. But many have been mounted, not just drug trials, the way we've been thinking about it, but applying them to population scale public health interventions, specifically in the air pollution and water sanitation and hygiene space. And so what we've seen over this last decade is a series of trials, large scale trials, sometimes tens of thousands of people with clean water, clean stove technologies that have primarily been underwhelming in their results. The health outcomes or the proxies people have been aiming for have not really been achieved. There's lots of reasons that could be the case, even if the target pollutant, for we understand it, is really reduced. So let's go into some of those problems. So if we think about household air pollution and cooking, the basic theory of change that we all operate in, most of us operating in the household air pollution world, is that, looking from the left-hand side here, that we make and provide through the market very often, but or an experimental means, clean stoves and clean fuels to people. That people in communities, primarily women, will use them in place of traditional more polluting technologies and fuels, and use them sufficiently, that is all the time, and completely replace what they've done traditionally. And then as a result of that, the air is much cleaner in their home, and they're no longer exposed to high levels of fine particulate, carbon monoxide, polyaromatic hydrocarbons, NO2, or other emissions that we know create health problems because of the observational studies that have been done for decades. And then we assume that as a result of that, people are healthy. As a result, we have made a difference in people's health. But if you look under the hood at that intervention, there's a lot going on. You have just starting from the left, how clean is the stove and how available and affordable is the fuel? Is it scalable? Where are they in that environment? And then at the stage of use, how easy are they to use? Are they using them because they're easy, or because they've told they've been clean, or can they afford them? What are they competing with locally? Is firewood free? And could they keep it up over time, even when they may have to purchase fuel from a marketplace? And then we look at the exposure reductions, and are we getting the reductions in exposure we'd like to see? and what are the other contributing sources of air pollution, be it heating, lighting, other household sources, or the ambient environment in which they are. Making a major investment in clean household and energy in Delhi during the winter, when fine particulate matter background levels are well above what we know to be health damaging, may make a marginal difference. Maybe it reduces it 10, 20%. We don't know if that makes a difference. And then finally, at the health effects side, do we have the right health outcomes in mind? Are we measuring them properly? What's the health background of the people who are there? Maybe they're already under such assault from nutritional conditions, stress of various sorts of diarrheal diseases, or a long history of exposure to these same ones that our intervention may not see results in a 1 or 2 month intervention period. So those trials don't necessarily indicate that there's a failure in that intervention, but we don't really know at the end of it why it worked or why it didn't. We have our theories, but we don't necessarily. Similarly, if we look at the water, sanitation, and hygiene world, the complexity of the world we're looking at that really takes place during intervention is much greater than most of us can manage in an intervention. So on the left here, you have a causal diagram of that many of you in the public health community have already seen versions of the relationship between diarrheal disease is caused by, at a baseline, transmitted through feces, via, touch by flies, through soils, drinking water, ultimately then through food or directly into a host. And the barriers that you can think about to make interventions, I don't know if you can see my cursor, are, do we fix it at the where people do their business? Do we try to make sure they have access to safe water? Do we do behavioral interventions that make sure that people are washing their hands and keeping them clean? Or do we try to do all of those? And will they work if we get them all done? So just that side of the system is pretty complex. On the right side, if we just take the safe water barrier and we look at what it takes to provide clean water in a low and middle income country environment with poor infrastructure to the household levels, you have this from the left-hand side, a very complex chain of partners and organizations that have to contribute and move just the system's wheels to make sure that affordable, clean water gets reliably to the household for people to use. All right. So those are sort of, thinking about the complexity that takes place in the middle there of why it's difficult. So that advocates so that's a reductionist way of managing the complexity. Break it down and look at all those pieces and parts. The other reason to think about reductionist context when we're thinking about how we make a difference, how consequences can be achieved, is because the world is dynamic, right? We have massive economic changes going on and at an accelerating rate in the US as well as around the world. This affects the infrastructure, the social and cultural dynamics, the demography of the populations we're working with, institutional changes that may or may not be able to maintain intervention or have competing influences that they arise and change, technologic and of course environmental changes, as well as epidemiologic. The picture here may give you an idea where I'm going with this, and that is, now we are looking at perhaps the largest and most threatening change of all to our ecosystems that involves every one of those contexts and institutions dynamics I mentioned before, and that is climate change. If anybody's read the newspaper recently, you will be very aware that the IPCC, came out with their recent report, and there's another coming out this year, which will be focused on health specifically. But identifying climate change is now at a code red stage for humanity, with disasters that threaten not just chronic health conditions, but extreme traumatic ones as well. And if you look at that in the global context, we think of what's happened in the last couple of years during a pandemic, where the world has been in enormous turmoil and almost shut down because of COVID-19. You see that doesn't slow necessarily climate change. While emissions slowed for a little while, they've picked right up, and all the accumulated changes in our system have created extraordinary events around the world, all of which have both direct and indirect effects on health and well-being, on public health. For all these interventions, the populations at most risk are really the underserved, under-resourced populations in the US, in developed countries, and especially in low and middle income countries. So I'm going to back up to the programmatic level for a moment. At the NIH, we have started looking at this, we've been sort of grappling with it episodically for a long time. And it has not risen to the top of the agenda to think about climate change per se as a health threat, and the complex of systems and how to approach it strategically. We've been able to do that this year with a lot more commitment, support from the White House and from Congress, and we hope to have a pretty sizable investment in our appropriation to be able to tackle that beginning this year, if our appropriation ever comes. So myself, as a co-chair of the working group on climate and health at NIH, and a large number of other people, have been working through what this should look like over the last 6 months. Particularly, we have a large number of institutes and centers involved, and I'd like this diagram to think conceptually about what those influences look like. So if you look at the top right here, where you climate drivers here, and how climate drivers will affect, through a series of exposure pathways, both extreme and chronic changes in pathways that affect, including population displacement, not just weather-borne, but pathways that then affect health outcomes. Everything from heat, cardiovascular and cardiopulmonary disease, infectious diseases, especially vector-borne and waterborne, mental health, and many others. And these are all affected through their interaction with environmental and institutional contexts. What else is happening in our systems, and what else is happening at the behavioral and social levels, which influence the way these are felt and experienced in health. Many of these have both direct and indirect effect. So again, we're talking about really complex systems here. And so if we want to intervene, let's say in one of these intervention pathways, we have to be very acutely aware of these contexts in which these are taking place. And we have come to the sort of recognition that transdisciplinary approaches are really the only way to do it. Public health scientists are not going to solve this on their own. Even very few individual threats without engaging in many other scientific disciplines, as well as communities and policy makers, among others. See if I can back here. So for public health scientists, the tools that we can think about consequences, we can understand that complexity and anticipate change, are many of the same tools that we have now. We just have to use, we used historically, we have to use them perhaps in slightly different ways. We have, a very strong grounding in observational epidemiology, and that still will be, the cornerstone of much work in public health, as well as the natural history and qualitative research about what people do and how we understand what they want and can and will be able to do. Technology plays a central role, both in mitigation and adaptation to climate to protect health, in everything from use of air conditioners and cooling systems to bed nets and clean cooking technology and water filtration devices. Technology does have a major role if it's used properly. Many people in public health look to program evaluation as a way of short-circuiting the long process to look at what's working out in the world and see what seems to have worked. And I believe that is still an ongoing tool. That would be part of the package of implementation sciences for many people. Increasingly, I think modeling and simulations are going to be necessary to be able to understand this complexity, as well as through experiments at many scales, both small scales and large randomized controlled trials. Implementation science, which I've alluded to a couple of times, plays a key role here, and I won't go into details except to say at this point that there's a series of tools that focus on strategies to how interventions and technologies are delivered, and the systematized way of looking at the delivery process, not necessarily the health outcomes, not looking at the biology or even the population dynamics of the problems, but how is that delivery process working? And I'm happy to provide you references if you're interested more in that. And then something that I'm particularly interested in, and I do think will be increasingly important, both as a part of implementation science, but also in many of these other areas, is systems sciences and systems tools that many people now use. The formal systems tools that we talk about, a systems approach, which is one in which we just think broadly and about the multiple influences on health and the multiple influences on an intervention to work. And three of the most commonly referred to ones are network analysis or social network analysis. There's agent-based models and system dynamics. Sometimes GIS also is thought of as a system science, and I think reasonably so. So let's focus down now again on climate and how these research projects may fit into understanding an outcome. So we know that extreme heat is playing a greater role in early morbidity and mortality around the world. And I'm not going to show you facts and figures here, but they're easy to find. And we know that chronic exposure, even to high heats without extreme heats, have long-lasting effects on multiple health outcomes. So, for example, preterm delivery of babies is quite common. We have increased rates of stroke for adults, especially elderly folks, in public housing during heat waves. cardiovascular events occur during and afterwards, sometimes associated with air pollution, but also just the heat itself. Kidney diseases, are now increasingly thought to relate to, and the epidemic of chronic kidney disease, CKDU, it's now being called, the syndrome in many developing countries is associated with dehydration because their heat and drought are combined to create chronic failure of kidneys, especially in farm workers and others with great exposures. So how do we take that on and look at those in research projects? Well, one way is to think about the mechanistic studies that many people at the NIH traditionally do, and many of the public health research community looks at health effects and in sort of biology. And others to look at the social and environmental determinants of health of those communities, often in observational studies, really important. Randomized controlled trials, if you have an intervention such as cooling or hydration for particularly vulnerable problems, and then implementation science, they've managed to make sure that whatever social behavioral measures or whatever interventions you're planning are delivered properly, accessible, and used by the communities to maximize their ability to have a health benefit. Oh, what am I going to seem to have lost? There we go. Okay. I want to come back to the technology question for a moment because we have in the public health world, and I think myself and my colleagues also frequently fallen prey to what the people in technology world refer to as the hype cycle for technology. We get very excited about an intervention that looks like it has a lot of possibility. That's often done with a little bit of basic research, some observational studies behind it, and a sense that we're attacking the right exposure, and we leap in. In the household, in the clean cooking world, there's been enormous hype for past decade around clean cooking to reduce respiratory and associated diseases especially in the developing world, providing these devices I mentioned before. I'm not to say it's not true, but it becomes the victim of its own hype if not managed carefully, if expectations are not managed. So what we have done here, both for clean cooking and for water sanitation and hygiene, is map the expectations, that is the hype of the general community, especially the policy and NGO community around a given technology, from the original technology trigger to sort of a peak of expectations that perhaps are inflated. And then when evidence begins to emerge, and we've mapped specific events over time to this, and it maps pretty well, you see a loss of confidence, and the development community begins to move away from it. Oh, this isn't going to work after all. People aren't really using the stoves the way we thought, and our early trials are not really working. So those randomized controlled trial failures that I talked about begin to really hurt us if we do them before we really understand what's going on. And then whereas commonly the case, there is then an area where we have a slope of a more gradual enlightenment, where we begin to see that where the problems were, and we begin to correct those and achieve the benefits that we aspire to at some level. I think this is where we are with the household air pollution world right now. We're at the slope of enlightenment. There will probably be more disappointments and more successes over the next couple of years. I think there's clearly, though, a place for this technology, and how and where it's applied really matter. And the same thing maps out for the water sanitation and hygiene community, for those of you focused on that. We got very excited about water filtration studies. They were applied all over the place. Early studies showed failures of the devices. People didn't use them. They used water from other places. And then some of them didn't work so well. They clogged, and maybe they got diarrhea anyway because there were other sources. And we began to have, a greater attention to what those problems were in the development and the implementation over time. So that's just something to be aware of as you map your career forward. My feeling is that what we need to go to in thinking about interventions is how to approach this with cautious expectations and tame that hype cycle, flatten that curve so that we don't get a big trough, but we make steady gains, knowing there'll be disappointments, and we move a little more expeditiously toward outcomes and approaches that will achieve the gains we have. This is especially true when we're looking at an accelerated erosion of the long-term public health benefits we have depended on for decades, and the gains that we've expected, come to expect in public health with climate change, which is happening at an extreme rate. I like this image because this is, I think this is at Perito Moreno, in Argentina, a glacier that I visited some years ago, and you can see this calving today. This is actually one of the few really relatively stable glaciers in the world that calves naturally, but that's accelerating as well now too. My point is that this is accelerating all over the world, and we have to figure out ways that we can do that. We can tackle public health in that context. One approach that a lot of people in the policy community are taking is to think about public health interventions and climate interventions with a sort of no regrets approach. Do things that we think, we believe have almost no downsides, even if it doesn't really achieve the public health benefits we aim for. It will have mitigation benefits, that is mitigating carbon emissions or CO2. Even if we don't reduce respiratory diseases as quickly as we'd like, we might be reducing blood pressure or other outcomes. So to make sure that we're measuring the right kinds, we're choosing the interventions we're focused on and measuring the set of outcomes we're interested in so that we can see what the benefits are and not declare each intervention necessarily disappointing or underwhelming at the outset, but make sure we choose those programs, policies, and interventions carefully. In the climate space, one of the ways this is being thought about is particular, again, how you think about climate and health together. So we know that active transport, cycling, is both better for people and reduces their dependence on, automobiles and buses and other emissions generating targets. So both climate and health, but there are many others that can focus to produce these. They produce less noise, that we insulate our homes, for example, and to note that these are all connected. Reduced solid fuel, as I mentioned, has many benefits. Even if we don't get the near-term outcomes we want in health, we're probably reducing climate emissions at the same time. So we need to be measuring that as well and thinking about that in our choice of fuels and technologies. Having people grow and use their produce locally, that has lots of benefits, both for health and for climate. The buzzwords, if you haven't paid attention in the climate world, are mitigation, that are mitigating the emissions that accelerate climate change, um, and adaptation, that is preparing our social, biological, ecological systems to withstand what is going to change no matter what we do on the mitigation side. One thing I haven't talked about, and I am really interested in, is how does carbon capture play a role into this? In the long term, I don't see any way out of this mess with just reducing our emissions and adapting our systems to it, not just for human health, but for our entire ecosystems. The amount of carbon stored in the biosphere is already producing changes that will unfold over decades. So even if we stop today, changes will continue to occur. So we need to do all of the above, but we should also be thinking aggressively about a really, really big, hard, massive scaled problem that is carbon capture and other ways to reduce the CO2 and other carbon greenhouse gases in the environment. So coming back to it, so there's no magic bullets. You know, I wish I was as excited about the next solution as many people are. It's not my nature, and there are lots of people you can talk to who will be as excited and probably deliver more of that. The thing that strikes me as one of the most important things is to take a systems approach, as I mentioned before. Think about what I just grabbed this causal loop diagram from a model published on irrigation water management. But the same things are now being developed for clean cooking investments, for water sanitation and hygiene, but not very few that think about the overall system. What are the social costs? Where are the interventions? Being very explicit about what your incomes and your outcomes, what you're focusing on, but then looking at what other subsystems are involved, be they irrigation or hydration, you know, social behaviors, economic behaviors, climate context for how you know, water management is subjected to external influences. You can't capture everything. You have to put a boundary around your system. But the more you understand the things that you are likely to bump up against, both during your intervention and as an outcome to it, and the sustainability of those over time, given all the changes we're looking at in the world, the better able I think we're going to be to make changes that are truly impactful. To my mind, those are all going to be transdisciplinary kinds of things, lots of stakeholder involvement, both community engagement, but also policy folks, and should be solutions oriented and not just purely descriptive. There's not to say there's not a role for purely descriptive research. It's really importantly underlines it. But if you're focused on making a difference, you know, and you want to aim towards solutions, this I think is one important approach. I'll stop there. I'm not quite sure how long I've taken. I hope I haven't gone over time. But if there are any questions, I'm happy to take them.
Any questions, please feel free to raise your hand or write it out in the chat box, whichever one is easier for you.
Maybe I'll start off. One thing that struck me as sort of central, you know, to your talk is how difficult it has been, and maybe will be even more difficult to conduct effective research on interventions or risk factors that are complicated, like the one that we're focused on, right? That requires a lot of things to move to make it happen. It just made me, the question when you went by that topic was, how maybe we're sort of biased or driven towards solutions that are simple. It just made me start thinking of the people who study things like vaccines. Really, although there are issues, it's not, the getting the intervention is often quite, in some places very complete and just sort of simple, sticking it in your arm, and it's a part of healthcare, which is pretty widely accepted. It just made me think that, I guess, I don't know if it's really a question or comment, but just, I was going to ask if you think this is sort of biasing the things that we decide to do. And then actually at the end, when you mentioned carbon capture seems like now we have this really massive problem. And at the end, we're going to get a big vacuum and suck it all up and make it go away. It's
right.
Not that it's easy technologically, but it's kind of simple. Just, if we had that machine, just press go and it would suck it up.
That's right. And in fact, none of those technologies can work at scale right now either. They all, are all mostly theoretical. The experiments they've done, could remove the CO2 in my house over a month, but other than that. So I'm just pointing really far out there because those projects are ongoing and they will have health consequences, whether people, so we need to think those through. So part of our job in the public health space is to look and see, to point out to people early on, look, this is really important. I know this is going to be taken on by large institutions. Let's stop and look at it carefully. Yeah, and I have focused a lot on household air pollution the last 5 years. And I think like many of us, I started out with a naive assumption that we can make a difference as simply as we can. And we can make a difference. It's a lot more complicated than many people thought. And simple interventions, unfortunately, lend themselves to hype. So, when, especially Kirk Smith got some early studies out there and started promoting it as effectively, this is a public health scientist who many of you may know or have known, who has passed recently. He was John's professor. People were so excited and leaped forward to to deliver the simplest intervention they could because it seemed incremental and easy. Give them a more efficient thing to burn their wood in. And then it turned out it really didn't do that much, either for climate or for health. And so we've now moved to clean fuels, which we think are likely to be more effective, but they have their own set of challenges and are not necessarily carbon neutral. So, I think what I'm saying more than anything is that environmental health interventions, now they're simple ones, right? You can put up screens on windows to reduce vector-borne disease, and the complications are modest. Bed nets also to reduce exposure work pretty well. Not perfectly, but if you use them, they reduce rates of malaria and other vector-borne diseases pretty well. But the more you have a system that requires a lot of behavioral effort and a lot of institutional investment, and it works at scale, the more we need to pay attention to the larger systemic role that plays and what the potential outcomes are. I'm optimistic in that I think we have lots and lots of really smart, passionate people working in all these areas. And environmental health, I think, is going to be the one of the most important sciences. I mean, I've always thought it was pretty central. But when you see the NIH, for example, which has historically been very focused on cellular, molecular, and clinical research, and lipid vaccines, of course, as the answer to many infectious agents. And you see that the agency is now turning, for example, to a much greater attention on social determinants of health, environmental determinants of health, and recognizing we have to pay attention to health more broadly than just focusing on a simple potential insult like an infectious diseases. And vaccines are simpler, but as you know, we only have in this country 65% of the population vaccinated. And in the developing world, it's in the single digits in many countries. So access is a problem. And, look, I've had 3 COVID vaccines. And how sustainable is that? So, anyways, I just want to say that to think more broadly about these things. I hope I haven't overwhelmed people or depressed them. My intention was the opposite, was to just broaden the horizons and think more about the complexity of the system you leap into.
I had a question about the health and climate co-benefits. I thought that was an interesting slide because for some countries who've already developed a specific infrastructure, let's say, like for China, who's developed their high-speed railway roads, right? How do they go about implementing like new infrastructure if they have already spent all of their budget on this one specific thing? Let's say they found like new research that says bike lanes are really helpful and people like promoting people's mental health, getting physical exercise and reducing air pollution. And they found out like they can actually implement this, but they've already just spent maybe like half their budget on high-speed railways. Is there like a way for them to like transition into that like bike lane sort of society, or they have to wait until they build back their budget? Like, how does it work for countries who've invested in specific infrastructure, but they're trying to change to what technology or the science is evolving to, I guess?
That's a great question, Kedarnath. And it's even worse because China was a bicycle society up until not very long ago. And in the past 2 decades, they have dismantled a lot of the infrastructure that promoted bicycles. As wealth accumulated, as people entered the middle class, their aspirations were to have automobiles and to travel more efficiently and in modern ways, was faster, et cetera. And along with that, a whole range of attendant health problems, including more pollution, more obesity, et cetera. At the policy level, how they make those changes is really complicated. And you're right. I think I'm not close to the Chinese policy. I mean, I've been to a number of US-China forums on these things. But they, of course, are balancing many competing interests at the same time, including the populist impulses, that is to satisfy the near-term needs of their of the population for, just more income, to have more food, to have better access to healthcare. And China is probably one of the leading examples, but not alone, among many countries that tried to follow the US and European model very quickly without going through all those stages. So they've leaped into a type of development that has enormous consequences, both for them and for us, for the whole world, as a leap to provide the kinds of lifestyles that we have made. And so now we're turning to countries like China, or tiny countries like Kenya, tiny relatively to speaking, and saying, oh, now you have to clean up your fuel combustion methods because the entire planet is warming. But of course, who produced most of that carbon. You know, we did. Most of the historical contribution, the thing that's creating that stored carbon in the atmosphere that is rolling out these enormous events is, you know, overwhelmingly. Now, the current emissions today don't look that way. The low and middle income countries, China, India, Brazil, you know, Russia have enormous contributions, while the US and Europe's are declining, actually, as a percentage at least. So those are really complicated challenges, and politicians and policymakers have to struggle with those. And it's not all about science, I'm afraid.
I have a follow-up question. Do you think it's possible for us to backtrack back to becoming more of a society that uses bicycles? And do you think the US has to be the one to set the precedent for other countries to like go back to like biking or like more active methods of traveling rather than using cars? Like, let's say Kenya doesn't already have like a major infrastructure for roads and stuff like that. Do you think we would have to set a precedent for biking and show other countries, look, biking's cool, you guys should do it too, sort of deal?
I think we and the Europeans and some other countries are, I guess, in the vanguard, if you will, of those kinds of moves, as well as, you know, renewable energy investments, and the degree to which those are accessible will be different around the world. You know, I mean, I've managed to put solar panels all over the roof of my house, and I've converted mostly, but I have the financial wherewithal to do that. It's not possible in a country like Kenya without massive government subsidies. Bicycling is an easy, you know, citizen level thing, and it is, as we set a model, I think we have long been a social model around the world. And the Europeans are ahead of us in a regard. If you go to, you know, Holland, for instance, it's much easier to bike than drive many places. And that's a model that we hope carries currency elsewhere.
Thank you, Dr. Rosenthal.
Yeah, my pleasure. Other questions? Luke, did I depress you? Oh. Hi, Katie.
Hi, Josh. I actually had a question. I don't know if Luke had a question or comment. Okay, first of all, thank you so much for your talk, Josh. That was really, really interesting. And, you know, as you know, I'm really exposed, no pun intended, to the household air pollution side of things, much like you are. But I also enjoyed seeing the other sides, like all of the other problems. Well, I guess I shouldn't say enjoyed because it's kind of overwhelming, right? But yeah. I was wondering, so you mentioned that with household air pollution, and you showed the figure, I think it was the hype cycle is what it was called. And we're in this slope of enlightenment, which I really like the way that sounds. But I was wondering what your thoughts were in terms of where household air pollution is headed next, because, you know, I think we're doing a lot of things right with the Happen study. At least I think we are seeing that we are, and we're hopeful that we are. But I was wondering what you were thinking in terms of what's next for HAP research specifically.
Yeah, that's a good question. Well, I think there are a couple of different areas that are really important. On the one hand, I think that we need to pay more attention to the local environmental context where we make those interventions. What's the ambient background? What's the social context and the cost levels to make something accessible? And the ambient background and the other competing fuels or contributing sources of pollution, to really think about where an intervention like LPG makes sense. So I think that's an area of import, and will sort of ground the implementability as well as the desirability of doing that in places. The other side that I think is really important is to think about, well, I say there are three avenues. The other side directly related to the household emissions and intervention part is other technologies. We can't ignore the fact that LPG is a fossil fuel. It's much more efficient, produces much less particulate and CO2 than burning wood. But there are leaks along the way that yield methane. The production of it and transport of it has lots of costs. It's a medium-term fuel, and in the long run, we have to get to whether it's electricity generated by renewable sources or alcohol from digesters, from crop residue. Those kinds of technologies, I think, are in the long term going to be really important. The third area is specifically on the health side that I think is really important, is understanding what the context for the health effects are. Many of the populations inhabit, we have some information about their background, but we don't really have a good handle on whether their nutritional background will allow them to see health benefits or not. Or their immune systems are just not competent to take advantage, or whether the historical exposure period of just HAP, but also other assaults on their health, will influence the health outcomes sufficiently that we will not make a compelling case to governments that they need to do this. And that's always the tricky part of this business, is how do you make the case, if you want for intervention, that it's worthwhile for a health minister, which has a very limited budget in the developed world. Do I take $1 million out of my BedNet program or out of my clean water program and put it into clean fuels? We have to really think carefully about what those costs and benefits are and be able to quantitate them in context. So I think those are all really important areas.
Thank you so much.
Well, thank you so much. I'm going to send a hand clap so everyone else can follow, I guess.
Symbolic hand claps. Well,
Yeah.
thank you for having here and indulging my slightly wandering big picture interpretation of events. Maybe sometime you'll have me back and I can talk about a little more granular studies on science. But this is
That was extremely
right now.
that was extremely thought-provoking, and we thank you so much for taking the time
Thanks all.
to present.
Bye, John. Bye, Luke.
Thanks, Josh. Thank you.
Thank you so much.